Hello to everybody, and welcome to this VJ Hem-Onc discussion in lymphoma. Today's discussion will be focused on large B-cell lymphoma, and we will try, with the help of my colleagues and friends that I will let soon introduce themselves, to discuss more how to select between CAR-T and autologous stem cell transplant for large B-cell lymphoma patients who relapse and require a second line or beyond. My name is Paolo Strati. I'm an associate professor in the Department of Lymphoma and Myeloma at MD Anderson Cancer Center in Houston, Texas. And I'm very excited to have the possibility today to have this discussion with my colleagues and friends, as I mentioned before, Dr. Evandro Bezerra and Dr. Andrew Jallouk. I would like to introduce yourself, Dr. Bezerra.
Thanks for having me here, Paolo. I'm Evandro Bezerra. I'm a faculty at the Cleveland Clinic in the Lymphoma and CLL group with focus on transplant and cell therapy.
Thank you. Dr. Jallouk.
Thank you again for the invitation. I'm Andrew Jallouk. I'm an assistant professor at Vanderbilt University with a clinical focus on lymphoma, cellular therapies, and transplant.
Thank you. Thank you both, Evandro and Andrew, for joining today. As I said, I'm sincerely very excited. I think the next half an hour will be a very productive discussion. So I'm going to very briefly just go ahead and set up the stage for the discussion that we're going to have today. So as a reminder for our audience, CAR-T cells, autologous CAR-T cells targeting CD19 have been formally approved by the FDA for the first time in 2017. At that time, for patients with large B-cell lymphoma, would require a third line and beyond. But then very quickly, they've been able to move up to second line, and maybe this will be even earlier lines in the near future. But since CAR-T moved to second line, they started challenging what used to be the standard at that time. There was platinum-based chemo, followed by high-dose chemo, followed by autologous stem cell transplant. And that is going to be really the main conversation for today. So before we dive into more details and before we learn more about your clinical practice and your opinions, why don't we maybe summarize for our audience the main findings from the two pivotal trials that have brought to FDA approval in second line, Transform and ZUMA-7. Andrew, would you maybe like to remind us the main findings and what your opinions are about those two trials?
Yes, absolutely. So the two trials that we're talking about, ZUMA-7 and Transform, are very similar in design. They were testing two different CAR-T products. One was axi-cel and one was lyso-cel. And so the idea behind these was to recruit a chemo-resistant population. So that's going to be important for our future discussions. So both trials required that patients either have primary refractory disease or disease that had relapsed within 12 months of frontline therapy. So those inclusion criteria were the same in both trials. And then those patients were randomized to standard of care, which is, as you said, Dr. Strati, a salvage chemotherapy with an autologous transplant, or the experimental arm, which was the CAR-T therapy, either axi-cel or lyso-cel. And in both studies, there was a very clear progression-free survival benefit for the CAR-T arm. And in the ZUMA-7 trial, that's converted into an overall survival benefit for axi-cel compared to standard of care. Now, there were some minor differences in trial design. For example, in the ZUMA-7 trial, there was no built-in crossover. So a large number of those patients, I think half or something, did end up getting CAR-T, those that progressed to the standard of care arm. In the lyso-cel trial, the Transform trial, the crossover was built in. But overall, very clear progression-free survival benefit and possibly an overall survival benefit as well, at least in the ZUMA-7 trial. Some nuances there that I think are really important to point out when talking about these trials is that a large number of patients who received the salvage chemotherapy did not end up having a response that allowed them to go to auto transplant. So if you look at these trials, the number of patients that actually got an auto transplant was much less than the number of patients randomized. And I think this is really important because what this is basically telling you is not if you have somebody who has a great response to salvage chemo, CAR-T is better. What it's saying is that if you have somebody who comes to you with no other information, if you do salvage chemo, there is a reasonable chance that they will progress on that. And if that is going to happen, then, all comers, you are better off going with CAR-T to begin with. And so I think this is a key discussion point that we should have later on, which is if you have somebody who has demonstrated chemosensitivity, even though they meet the criteria for these trials, what should you do with them. But to summarize, basically, if you have a patient who comes to you, no other information, you are better off from a progression-free survival and potentially an overall survival going with CAR T right off the bat.
Thank you, Dr. Jallouk. And I'm going to put a pin on that. I think it's really interesting that you brought up the intent that both trials had in both arms, and trying to clarify whether the intent was being able to get to transplant or not, but majority of patients actually in the transplant arm didn't. And so one point chemosensitivity. So I'm going to put a pin on that and discuss a little bit more in a second and ask you more questions. But before we talk about that, I was thinking, Dr. Bezerra, if you could maybe share with us what your thoughts are instead regarding the third study, the BELINDA study. Of the three was the only one that was negative. And because of that, currently, as we all know, T-cell or Kymriah remains approved by the FDA for large B-cell lymphoma, only in third line, but not in second line. Can maybe summarize for our audience what the study design and main findings are, and why, in your opinion, this study was negative as compared to Transform and ZUMA-7?
I think the BELINDA trial has a very similar design to Transform trial, right? Both are 4-1BB CAR-T19 products, and in both allow bridging chemotherapy in the patients randomized to the CAR-T, while in the ZUMA-7 one key difference, they only allow steroids as bridging therapy. Among the reason that the BELINDA trial did not CAR-T arm did not outperform the salvage platinum-based chemotherapy followed by stem cell transplant with response. I think there are several hypotheses to speculate why there's difference. One could be the CAR-T product. Another important difference is the time for manufacture. The median time for manufacture for the T-cell was significantly longer. I think the time from apheresis to infusion was about 52 days. And in the T-cell, while was significantly shorter in the lyso-cell and also in the X-cell. Also, the prime endpoint definition, like in both ZUMA-7 and Transform, they use EFS, and the time point for EFS in the Transform was 9 weeks. And if the patient requires second type of salvage therapy in the stem cell transplant arm, that would consider an event, while in the BELINDA trial, it was at 12 weeks time point, and if the patient have not responded to the first salvage therapy in the stem cell transplant arm and have a second type of salvage, that would not be considered an event. And also the lack of initial response, if you have stable or refractory disease or progressive disease by 12 in the CAR-T arm, was considered an event, while in the other studies we require a disease progression. And we both know that in CAR-T field there is patients that have the late responders at the initial reassessment of disease. We don't see a clear response. It's sometimes because of the CAR-T traffic to the disease site, and then later they can have a delayed response. So it's hard to pinpoint the reason this trial was not positive, but that is the most popular possible explanations that we suspect that this trial did not show that CAR-T outperformed to the salvage-based chemotherapy followed by stem cell transplant.
Thank you, and thank you for bringing that up, Dr. Bezerra. And I feel like the common denominator, as we try to highlight the overall strengths and weaknesses of these three trials, is really trying to better understand and define the overall concept of chemosensitivity. And I feel like there are really two levels of chemosensitivity, one for eligibility, in this case for the trial, so chemosensitivity or resistance to frontline chemo, to an anthracycline-based chemo that also has translated for axi-cell and lisa-cell into an FDA label, but also the definition of chemosensitivity when it comes to, for those patients who received the platinum-based salvage chemo. So I'm going to maybe ask you more questions about that. And I'm going to go back to Dr. Jallouk. So as we mentioned, currently in the FDA label, Yescarta can be utilized for patients who are primary chemorefractory in second line, and there's a very arbitrary cutoff of 12 months within which the relapse happens. Of course, I think we all agree it's very easy to define what's really primary refractory, so the very rare aggressive lymphoma patients who don't respond at all to frontline or CHOP or EPOCH. But can you tell us more, in your opinion, what should be considered chemosensitive in terms of relapse after frontline anthracycline chemo? What are your biological and clinical thoughts, and what has been your practice beyond the FDA label?
Yeah, so I mean that's a great question. So like you said, with the FDA label that provides an arbitrary but very clear threshold of what is likely to get approved by insurance versus what is not likely to get approved, right? So if it's earlier than 12 months, you have the label behind you. If it's later than 12 months, then you don't. And so, I mean, I think looking at chemosensitivity, it is a biological phenomenon, right? But we are using clinical variables to try to interpret it. So obviously, response to the initial frontline chemo is important to look at. But even in patients who are primary refractory, like you brought up, if you look at the PARMA trial, which is where autologous transplant was initially established, about 20% of patients who are primary refractory actually ended up responding because it's a platinum-based chemo. It's a different kind of chemo regimen. So even then, I think there is some question as to what exactly chemosensitivity means. And so, I think what happens in my practice a lot is not that I'm going to be making the decision. So I can tell you if I have somebody who's an all-comer, just coming in, new second-line diagnosis, I follow the label. So if they're within 12 months, I go for CAR T again, because in that population, for whatever reason, we can talk about the trials, there is a event-free and an overall survival benefit. If they're past 12 months, then I can't get the approval anyway. And so, I will try the salvage chemotherapy. But the real question is, what happens if somebody comes to your practice who has already gotten chemotherapy from an outside physician? Or what are you going to do if you have delays in getting your CAR T approved, and so you give holding therapy, and then they have a response to that? So these are situations we find ourselves in all the time, and I think they're very difficult to manage. I will say a lot of times what I will do is, if we make the decision to start with CAR T, we will try to get insurance approval and get them to CAR T as fast as possible. If they need holding therapy, we will give that. And especially if we have the CAR T ready, we will sort of execute on the plan as planned. And so we will move forward with the CAR T. It's a different situation, I think, if a patient comes into your clinic having received second-line chemo from an outside provider and is in good partial or complete response. I do practice differently there. So there was a CIBMTR analysis done, as well as some other papers that were published that showed a benefit to doing auto transplant in these, what you would call proven chemosensitive population. So I think that is a little bit different story. But again, we're using clinical variables to define all this. I would love if there was a laboratory or a test that we could do to define, is somebody likely to respond to chemo? Is somebody likely to respond to CAR T? And, I think that's going to become even more important if some of these current trials like ZUMA-23 and some of these others read out that are looking at CAR T in the first line setting. So I think there's a lot to go on there, but I'm not ready for practice.
No, thank you. Say very nicely, and thank you was a perfect segue for the second part of the question. So I think what we're hearing is it's kind of a no-brainer when it comes to definition of primary refractoriness in terms of sensitivity to frontline anthracycline-based chemo. Because as Dr. Jallouk said, currently, unfortunately, we have to go by FDA label. So complete lack of response to frontline anthracycline-based regimen or relapse and progression within 12 months is what we have to follow to be able to get access to second-line CAR T, no matter how arbitrary it is from a biological or clinical perspective. But as Andrew started to mention, and that will be my question for Evandro, the hardest part is trying to define chemosensitivity and chemoresistance to second-line platinum-based chemo. Well, we all have, I agree, different approaches to bridging therapy or holding therapy as we wait to make a decision or we wait for logistics to resolve. I would say still many academic physicians and definitely the majority of community oncologists do utilize platinum-based chemo in second line, no matter what the response was to frontline anthracycline-based chemo. And Andrew mentioned the 20% response to platinum-based observed in the PARMA study in primary refractory, anthracycline refractory patients. And you started to mention the CIBMTR study. So just to summarize, and I'll let Evandro comment more on this, there are studies demonstrating that for patients who receive a second line or beyond platinum-based treatment, and they achieve a PR initially in the first study and then a CR in the second study, it's debated whether we should use autologous stem cell transplant or CAR T. So I was wondering, Evandro, if you could comment more on those two studies, the CIBMTR experience. What's your opinion about those specific study designs, and what's your practice for patients who get a second-line platinum-based chemo and they have some degree of response, PR or CR?
This is a very important study published by Maisar Shadman from the Fred Hutch. So the first one, as you mentioned, patients in PR published in Blood that show that patients that achieve PR to salvage chemotherapy and retrospectively compared to the patients that receive CAR T versus auto stem cell transplant. At least you can say this auto stem cell transplant is not inferior to CAR T. And then later, he also showed the same similar findings in patients that got complete remission. He's published in Blood Cancer Journal, showing that patients that got complete remission to salvage chemotherapy and then went through stem cell transplant or CAR T, stem cell transplant was at least no inferior, and there's possible superiority. And so I do, it's very hard to change because we are like, I think the best quality data we have is prospective randomized trial, right? And looking on that in the prospective randomized trial, that when you have this patient population of less relapse in less than 12 months, I think even though you have this data retrospective showing that there is possible non-inferiority of stem cell transplant if you have a remission, I think it's very hard to, based on retrospective data, not follow randomized clinical trial. I agree there's a very heterogeneous population on this patient population that have relapsed less than 12 months. I don't think everyone on that patient, like primary refractory and early relapse, probably are not the same disease, not that they don't have this, don't share the same biological factors and may not be have the same prognosis. This comes a lot from the publication from Farouk at the British Journal of Hematology back in 2017 that showed the difference in outcomes. Patients have primary refractory disease and early relapse and late relapse disease. So in this patient comes either because I give the holding therapy or they receive the holding therapy from a referring physician and they come with a remission. I try to explain the data available. If they fall in the category of relapse less than 12 months, had a remission, showed the trial data of the prospect data showing favorable outcomes with CAR T cell over auto stem cell transplant, but also try to show the data of the retrospective data. And one thing I like to highlight is we have a lot of data of CAR T after stem cell transplant, right? It's third line, like that's how CAR T started, right? But we don't have a lot of data of stem cell transplant, auto stem cell transplant after CAR T. And we know, like Dr. Jallouk mentioned, auto stem cell transplant, even in patients with refractory disease, was able to offer a curative treatment option for a subset of patients. And when you use the CAR T before the stem cell transplant, are we going to be able later to use that treatment option later down the road? So a very interesting question. I have a couple cases in my clinical practice of success. You're doing an auto stem cell transplant after CAR T.
Yeah.
But if you go look back, if you go to the data, it was very rare nowadays. Patients going to get an auto stem cell transplant after the CAR T.
First of all, I really like the fact that you try to have a conversation with your patient, just discussing data, the trial data, but then also the real world data, and trying to make this for patients who may be potentially eligible both for CAR T and transplant, kind of a provider-patient discussion, and having the patient engage as much as possible in the decision-making process. And I'm also very excited that as you both talk, you're actually, and there was no agreement before we met on what we would specifically ask. They're actually bringing up the same question that I had in mind. So clearly, in the community, we all have the same challenges and the same questions in mind. So let me ask you a few follow-up questions that maybe I'm going to ask to both of you. And actually, let me make a comment first. As for patients who are in PR after platinum-based second-line chemo, we did publish at our center kind of a provocative follow-up study where we looked into TMTB, and we were able to demonstrate the answer should probably be more biological than clinical. So patients who had the low TMTB, they may speak to low tumor burden and as such a less suppressive tumor microenvironment tended to do better with CAR T as compared to transplant. But those who had a relatively higher TMTB, where there was more immunosuppressive microenvironment, as long as the PR was a reflection of a true chemosensitivity, because not all PR are the same. You can have a decrease in disease from 100% to 50%, but from 100% to 10%. So there are different degrees of PR. So if the PR was a reflection of chemosensitivity, it didn't matter how big was the tumor burden, then transplant would be better. So going back to what Andrew said, that with time, hopefully we're going to develop biomarkers to make a decision. But let me ask you again, a couple of follow-up questions for both. So we all know that in second line, Breyanzi can also be accessed for patients who are primary chemorefractory, but overall transplant ineligible. And while I acknowledge that, definitely there's no universal agreement on what's CAR-T eligibility, but some agreement on what's transplant eligibility, many times transplant eligibility is in the eye of the beholder. Could you maybe both of you comment on what would be the typical transplant ineligible patient for you? And it's not somebody that but still CAR-T eligible. Maybe we can start with Andrew or.
Yeah.
Yeah.
Sure. Yeah, I mean, I can talk a little bit about how transplant eligibility is handled at our center. So, any patient over 65 going for either an auto transplant or CAR-T gets a formal geriatric evaluation, and that those are certainly helpful for informing patient frailty considerations and things like that. I will say, in terms of I personally don't like the terms eligible versus ineligible. All of these things are risk-benefit discussions with the patient. Like if you gave me a hypothetical patient who had a 90% chance of dying during their procedure, but 100% chance of dying without it, and they were willing to take that 10% chance of cure, that is a discussion that you have to make with them. Now, this is totally hypothetical. But the point being is I think you need to weigh the options on one side and you need to weigh the options on the other. And, liso-cel is a generally pretty well-tolerated CAR-T, I mean, especially compared to some of the other options. And so that takes the risk down a little bit. And honestly, now we need to have the discussion with bispecifics as well. That's a whole different conversation, but it is no longer that, you need to have a CAR-T or an auto or you have no reasonable treatment options. I won't say curative, that's a different discussion. But everything should be a discussion with what are your options, what are the risks of each option, and what are the benefits. And so, in terms of who is CAR-T eligible, I would say that I think CAR-T is a generally lower risk procedure, especially with liso-cel than auto. And so I'm a little bit more flexible in terms of who I would recommend or suggest go through CAR-T. But I mean, I don't like firm numbers or anything like that, especially when it comes to age. It really is, I think it is a risk-benefit discussion with all the options, which include salvage chemotherapy and transplant, CAR-T, and now also bispecific and bispecific chemo combinations.
Thank you. And Evandro, again, I'll be very mindful in not utilizing the term eligibility, but could you comment more, in your discussion with patients regarding transplant versus CAR-T? What are the elements that would maybe make you lean more toward one or the other?
I agree with Andrew. Like, if I don't like the term transplant eligibility, and I would challenge that to be very different to have a Hodgkin patient, right? We would be much more inclined, or a T-cell lymphoma patient that would require an auto stem cell transplant. We wouldn't follow so specifically like age cutoffs of 65 or 70 years, like on the pilot on the Alkaline trial, and some comorbidities, like as we have the comorbid assessment, the genetic assessment. But I think because we do have in diffuse large B-cell lymphoma a very good treatment option, curative treatment option like the CAR-T cell, makes you less willing to take the risk of the stem cell transplant. So I agree, like my cutoff for eligibility for stem cell transplant in diffuse large B-cell lymphoma is significantly lower because I have the CAR-T option versus in other lymphomas like Hodgkin or T-cell lymphomas that we don't have that CAR-T option.
Perfect. Now, as we're running out of time, I'm going to ask maybe 3 final questions. We'll try to address in the next couple of minutes. So the first one, Evandro brought up a very interesting point. Let's say for patients who may be potentially eligible for both, we have very old and long-term follow-up data clearly showing that you can use CAR-T after autologous stem cell transplant, but not vice versa. But I think we all have developed some experience. Maybe Andrew, have you had any experience, successful experience, in consolidating with auto in patients who relapsed after CAR-T?
I mean, I will say I haven't, but it's probably for lack of trying more than anything else because we have so many other options. I mean, we have bispecifics now. We have a large number of trials that these patients are eligible for. So I think it's rare to see the CAR T patient or a post CAR T relapse patient that we would not do these other options in, but we would do chemo and also has slow enough disease that we could do chemo and then get to an auto transplant. As you know, a lot of these post-CAR relapses, the issue is they're explosive and it can be difficult to manage. So I will say that I haven't necessarily had that experience. I certainly believe that, especially if you're using CAR T in the second line setting, there's probably some proportion of patients that biologically won't respond to CAR T, but would have been chemosensitive and would therefore, respond and potentially be cured with a transplant. Because of all the other options,
Right, that's a nice segue, and we'll see maybe what the data will show in the near future as we develop more and more real-world experience. So, follow-up question for Evandro, and then I'll ask a final question to both. It can happen that you may have in front of you a patient is like ideal candidate, both from a patient factor perspective and lymphoma-specific factors for both CAR T and transplant. So thinking that you may have this ideal patient in front of you, is there any logistic or access-related issue that will make you lean more toward one or the other? And has the mitigation with elimination of REMS requirements to stay around a CAR T-cell center for 4 weeks and decrease to 2 weeks in any way affected your logistical considerations?
I think from the logistical standpoint and access standpoint, the CAR T cell is more accessible than this auto stem cell transplant, right? You have much more and time consuming as well as the stem cell transplant is much more time consuming. You have the mobilization, the apheresis for the collection stem cell transplant that's similar to the CAR T. You have the apheresis to collection of the T cells. And then the transplant itself, patients needs to be under the care of the transplant center a longer period of time, the CAR T, especially of the flexibilization of the REMS criteria. So for me, most of the times I see my patients in discussing about the two options, be more inclined to the CAR T option because it's less time consuming and much more flexible than the stem cell transplant. It's hard to me to think a patient that from a logistics standpoint would be able to do the stem cell transplant and not be able to do the CAR T. I cannot think it.
Yeah, I agree. Agreed. And definitely, as I mentioned before, also with the mitigation of REMS requirements, that makes for sure CAR T a preferable option from a logistical perspective for patients who would be otherwise, I'm not going to say eligible, but a good fit for both. So very final question. I think it's important for our audience to be aware that when it comes to CAR T prescription in the US, most of centers will defer the prescription to transplanters and other centers to cellular therapists who are not necessarily transplanters. And I'm very happy that today there's a representation of both, with Evandro having more, a transplant training and having been born as a transplanter and then doing cellular therapy, and Andrew being more a non-transplant cellular therapist. And I wonder, well, I think that we all agree that since the pivotal trial in third line and then in second line, there's been a meaningful decline in the prescription of transplant. Whether you feel that based on the setup of the center where you work, so being the prescription of CAR T deferred to transplanter or CAR T or cellular therapist, there could be a difference in the frequency of prescription of CAR. Has that been your experience? Let's say, Evandro, you're more of a transplanter. You were born as a transplanter. Do you feel like there's a difference based on the setup of the academic center where you work?
I think I'm not sure specifically where I work, but definitely I think there is who is transplant training and more experiencing patient successful cases of auto transplant and also seeing the very low toxicity of auto transplant. Like so, and we in the it's very very rare to have a case of non-relapse mortality. Very very rare to a patient after stem cell transplant go to the ICU. So having that experience makes you more flexible and consider that therapy option than someone that doesn't have the experience dealing with the complications of the stem cell transplants. I think that definitely may play a factor the provider that's prescribing the therapy experience with both therapies, seeing because we always say that it's our stem cell transplant have like a higher risk of complication than CAR T, but is that true? I question that. I think the ICU transfers if you look in ICU transfer patient getting CAR T and auto, I would challenge to say that's more frequent ICU transfer with patients getting CAR T than stem cell transplant.
And as a cellular therapist, non-transplanter, hearing what you just said, it's actually really powerful. So I'd like to, conclude hearing from Andrew what his thoughts are.
Yeah, I completely agree with Evandro. So at our center right now, a patient is referred, and then it's the transplant and cell therapy groups very, very closely overlap. And so it's usually kind of a joint decision by the group which one to go with. And so I do think that puts them a little bit more on an equal footing in the sense that, the group is familiar, the groups who are making these decisions are familiar doing both. And they can take a little bit more of an objective balance of which one is right. I think anytime this is true across even beyond lymphoma, anytime anybody can do one procedure but would have to refer out for another procedure, that very much creates a barrier, and it tends to favor whatever procedure can be done, in-house or in department. But I will say, the current practice model I'm in, I think works very well, and we don't run into that much.
Well, thank you. Thank you so much. I think our time is over. This has been a very dynamic and insightful conversation. Thank you to Vijay Monk for supporting this conversation. Thank you to Dr. Jallouk, Dr. Bezerra, Andrew, Evandro for joining us today. And thank you to our audience for listening.